Good afternoon, everybody, and thank you again for joining us for another one of our MAG special series. Today we have one of our Meet the Specialist short sessions, and it is my absolute pleasure to have with me today Dr. Katherine Brown, who is a sexual and forensic health physician. So Katherine's just going to tell you a little bit about her specialty and how it may relate to your medico-legal matters. It's actually a lot more than you really think it is, so it's quite interesting. Over to you, Dr. Brown.
Thank you very much, Michelle. For those of you who aren't aware of what these specialties are, and I realise they're quite niche in some respects, sexual health has been recognised as a specialty since 2009. But prior to that, it's been a specialised field of medicine and probably really came into its own during the HIV/AIDS crises of the 1980s and 90s, when people realised that actually all those nasty diseases hadn't gone away, having thought that syphilis and gonorrhea were not much to do with anybody. It became obvious that actually sex was related to some quite problematic diseases. And of course, HIV and syphilis both cover a lot of other areas of health. So there are skin diseases that can be associated with them. There are hematological problems. There are ophthalmic issues. And so many specialists do come across people with HIV, for instance, or with syphilis, incidentally, on a referral perhaps from GPs who aren't aware of the background of whatever the presenting problem is. In terms of the link to forensic medicine, the training for sexual health has always involved the management of sexual assault, acute management of sexual assault, STIs, HIV, sexual function and reproductive health. And so the crossover into sexual assault is where the forensic medicine comes in. So I currently have fellowships at the College of Physicians in Sexual Health and at the College of Pathologists in Clinical Forensic Medicine. That faculty in the College of Pathology occurred about 10 years ago. And so there are a number of us who were grandfathered into the college in order to start really recognising forensic medicine as a specialist field. And it involves more than domestic violence and sexual assault. It does involve the management of toxicology, prison medicine, a number of other areas related. Basically, forensic anything means the connection between the law and whatever the field is. So forensic psychology, forensic medicine, forensic accounting is the intersection of law with all of those things. In terms of sexual health, I probably provide a few certificates in the medico-legal field relating to sexual health, primarily when somebody has acquired an infection, particularly a child, but anybody who's acquired an infectious disease and there's a possibility that there might have been associated with a crime. So in terms of children, has the person got an STI at an age where they are not legally supposed to be having sex, and therefore the person having sex with them has committed a crime, and this aggravates the crime. In terms of the forensic medicine side of it, I do reports for police, for the DPP, and sometimes for defence in relation to particular stories that are told. They may sometimes relate to sexual function, they may sometimes relate to STIs, and they often relate to injury or to whether or not it's possible that particular things have occurred in the manner described. I have on occasion provided reports for people who have died, but that is a very rare event. Generally, forensic medicine deals with the living and forensic pathology deals with the people who've died. But in the case that I was involved in last year was a very long-standing historical case that went to court again in November last year. It related to the possibility of a sexual assault occurring in association with the death. So in that case, my expertise related to the sexual possibility of sexual assault, not to anything related to how the person had actually died. It's a field that is very interesting, and I look at other injuries. Sometimes people will present with assaults, and the police will be looking for, the DPP will be looking for an explanation, because police and the DPP, of course, can't interpret injury. That has to be medical practitioner, and there are a lot of medical practitioners who are frightened of going to court, or they don't want to get caught up in the time. But it is a very interesting field, and if you sort of take it down to the lowest level of what could have occurred and why and what the injury looks like, you can often avoid going to court by writing a very good report that explains that for the court, and the court will therefore take that as accept the evidence without having to attend the court. That doesn't happen on every occasion. The other area that I've been involved in at times, which has involved me going to court, is cases where health professionals have behaved inappropriately or have been alleged to have behaved inappropriately, and there may be one or more complainants who make that allegation. And in that instance, it's a matter of going through all of the records that are provided by police in relation to the allegations and looking at whether or not the medical or other health care was provided in an appropriate manner. Sometimes it's a misunderstanding. There may have been a communication breakdown and somebody hasn't actually explained very well how or what is going to occur and why it needs to occur, which is often the case for any complaints that we know that people complain partly and quite frequently because of communication breakdown. And often, if you've really explained things well to people, you can avoid getting into strife. However, there are people who do have inappropriate behaviour, sexually touching people, undertaking genital examinations when there is absolutely no good medical reason for that person to have any removal of clothing or any contact with the genitals. And in that instant, if somebody's done something inappropriate, then that needs to be explained to the court as to what ought to have occurred in that situation and why it was necessary or unnecessary to undertake that activity. And that then allows the court to understand what's going on. We, as you know, are, when we go to court, there to provide information to the court. So we are not there to take sides. We are there to explain an issue and to look at the issue if there are problems with the evidence that's being presented, to point out why this particular piece of evidence might be problematic if we think that it is so. And so our role is not to take one side or the other, is to present the facts and to explain the facts. And so when I write a report, I write very detailed reports explaining, I use appropriate medical language, but I also break that down into language that the layperson will understand, because judges may have quite a lot of experience and barristers may have quite a lot of experience from the amount of work they've done, but the jury will have very limited experience. And even the legal profession operates in a different way. They have a different language, the same as medicine does. So we need to be able to explain clearly to all of the participants in the court process what the actual evidence suggests, and provide an opportunity for the court then to take that into account. And I think the important thing with any kind of forensic reporting is that we are not the only part of we're not the people who make the final decisions about anything. We are part of the evidence being presented, or we're presenting part of the evidence, and we need to do that clearly and concisely and allow the court processes to occur without without providing any level of bias, because that is actually unhelpful to any of the parties in the court process.
Right. Thank you so much. Dr. Katherine, I know through many of the reports that I've seen, your reports, which are beautiful, and certainly the legal inquiries that we receive in our business at MAG, that this can cover things such as, is it rape if the person achieved an orgasm? How does a person tell whether they obtained a sexually transmitted disease from a current partner or from someone else, and all of these other things. But I've had a question from someone that's a little bit out of left field, somebody who couldn't attend today, and they're asking if in the field of your specialty, are there increasing queries coming to you in relation to people who are transitioning of gender or who are considering themselves to be not of their birth-assigned gender? And how does that impact your role in sexual and forensic health?
I don't think there's a major forensic component to most of the people presenting with transgender health-related concerns. Certainly, there is definitely an increase in the number of people presenting to discuss their wish to change or to be recognised as having a different gender from the one that they were assigned at birth. In that instance, there are sometimes quite complex neurodiverse issues, psychological issues that also need to come into consideration. And whilst people do need to be able to make choices, we also have to, from a health point of view, always look at the whole person, look at their health, look at whether there are, what are the factors there, how long is the person identified in a particular way. One of the issues, having been in this kind of medical field for a long time, in years gone by, people did present to us with with gender identity issues in the sexual health clinics. And at the time, we were not really encouraged to have much to do with that field. We were very much directing all of our attention to STI and HIV, whereas now we have a broader remit in the public health arena. And but at that time, there were fewer people. One of the things that I observed at the time was that there were some of the people who presented wanting to transition from one to the other, from their gender that was assigned at birth to the alternative, was some people thought that all of the problems they had in their life would be solved by changing gender. And some people had such significant mental health problems that may have originated from their gender concerns, but certainly changing gender wasn't going to address all of the problems they had. They had significant other problems that needed to be addressed, and that was not the sole it's all fixed solution. And so that's something we know also, that there is quite a high percentage of the people who do present for transgender concerns do have have neurodiversity, and for some of those people life is a bit complex, and so that also complicates sometimes for them how they manage that transition. So for some people it's very readily managed medically and psychologically, and for other people there are struggles they have. They sometimes become embedded in what they think they should be entitled to. And as medical practitioners, we always have to look at what the evidence says and to look at the health risks associated with the health benefits of doing any particular medical procedure or using a medication. And sometimes that's complicated if people have in their mind that they need to have very, very high levels of hormone, much higher than anybody who is genetically male or female would have, because having very high estrogen or having very high testosterone is bad for your health. It's a problem for health. So we have to be careful in the management and how we manage people's expectations and desires, because they may think they want something that isn't medically healthy, and may feel that they're being discriminated against if we say medically that's not the right thing to do.
Yeah, so I guess do you think that there will be down the track more medico-legal cases or claims where people believe that perhaps they should not have been allowed to transition or should not have been given these medications and then develop complications?
I think we'll have claims either way. I think there will be people who say, I can provide all this evidence that says that I have always identified as something. And then there'll be people who say, I was unwell at the time and I thought this was the right thing, and doctors went and did X, Y, or Z. And I think it is a very complex area for adolescent management when you're looking at puberty blockers, for instance, because there's a school of thought, again, that says, where people say, well, I have the right to do X. And the issue with puberty blockers is that if you do use them, you can then delay the processes that might make it more difficult to transition. But there are certainly changes overseas looking at issues around, are we overdoing these things, and how do we select, maybe select's the wrong word, but how do we ensure that the people for whom we choose particular types of management are getting the best outcome? And I think it's quite a fraught field in terms of what is the best outcome for people.
Yeah, wow. Look, the information that you've shared with us today is certainly very, very interesting and thought-provoking, and I hope that has given our viewers a little bit more information about what the specialty of sexual health does and the area that it covers, which is quite broad. So the very lovely Dr. Katherine Brown is on the MAG panel, and she is available upon request for your matters. If you have any questions that you would like to ask of her that you didn't raise today or that didn't get to me, please let me know and I'll forward those to Dr. Brown for her consideration. But as usual, you can check this video out on our YouTube channel afterwards. And we thank you so much for joining us for this short Meet the Specialist session today. Thank you all and have a great rest of the day.
Thanks, Michelle.
Thank you so much. I'll just stop that.